name is Adele Houghton, and I am both an architect and a public health practitioner. I think of myself as a translational and transdisciplinary researcher and practitioner, and you'll see some of that in the remarks that I make with you all today. The idea being that there's a lot of research that's been done in kind of silos of different disciplines, whether it's medicine, architecture, climate change. And the work that I do tries to connect the dots and help, particularly when we're designing or renovating facilities or any type of building, that we're able to bring a strategic lens so that anything that we do, once we're done, will have a positive ripple effect on the surrounding neighborhood, whether that's related to climate change, to health, to social equity, et cetera. And so today we're going to specifically talk about people with differing abilities. And I think I was really excited to meet Dr. Alexander a few years ago and begin to think in more depth about how, many times when we talk in public health about people who are at risk of negative health effects related to climate change, when we talk about physiology, we talk about children who are, less than 5 or adults who are over 65. We talk maybe about immunocompromised patients, maybe cancer patients. But the conversation about people who have different types of disability, whether it's physical or cognitive or other types, seems to be kind of embedded underneath the conversation. And obviously, if you're, say, a cancer patient and you just finished treatment, you might be more likely to be mobility impaired, right? But we don't talk about the mobility impairment itself as potentially an amplifier of risk to climate change. And those of us who are in the profession of building and maintaining and renovating and rebuilding the built environment really need to think about the breadth of different types of people who spend time and move through spaces that we design and construct. And so thinking about climate change and disability, both from the perspective that being exposed to a climatic event like a hurricane or extreme heat or wildfire might actually lead someone to have or exacerbate an existing disability. And then also thinking about how, when we're building and maintaining the built environment, when I say the built environment, I'm really talking about buildings, sidewalks, streets, transportation systems, everything that we spend our time in and move through in the human society is essentially the built environment. And whether or not the climate change created or exacerbated an existing disability, it's something that we need to pay attention to in all types, not just looking at limited mobility. And so we're going to talk about that in a little bit more detail. The built environment itself has the ability to facilitate well-being, right? So if you think about where you live and compare it to maybe a place that you visited, and you think about where you live and how you get food. Do you walk to the grocery store? Do you drive to the grocery store? Do you take a bus? And then maybe you went to an unfamiliar place and you were trying to do those types of daily activities in a different built environment, a different setting. Sometimes it can be a little bit disorienting and hard to navigate, right? And I would argue that a built environment that is designed with people at the center of that design would consider that situation and try to ensure that it's easy and inviting for any type of person to move through a space or through a city and access the amenities that they need, be able to make it to their appointments on time, have access to medical care if they need it, that sort of thing. And so the purpose here, when we're talking about how we design the built environment, is really breaking down what those design strategies might be, so that when just an ordinary person is spending time in a space or moving through a space, they don't even necessarily think about it. Maybe they think, wow, this is a beautiful place. I enjoy being here, but they're not, the design has been embedded into the space so well that they don't even recognize the kind of the open pathway that's been set forward for them. So as Dr. Alexander mentioned, I have been working on a book. It's called Architectural Epidemiology. And this is the conceptual model for this proposed new transdisciplinary approach to research and practice. And it really thinks about architecture and changes, land use, changes to the built environment as an active participant in public health interventions. And you can see, I know that the slide's kind of small. We're going to go through this in a little bit more kind of zoomed in, but the top half is dark gray and the bottom half is light gray. The top part is drawing from environmental epidemiology methods, and the bottom half is drawing from social epidemiology. And the reason why architectural epidemiology draws from both of those methods and traditions is because buildings and land use make a tangible change in the surroundings and the environment. They change how hot it gets, how much you feel that heat. That's called urban heat island. They change your risk of exposure to flooding. They change traffic patterns, and so exposure to air pollution. They make changes that actually alter exposure pathways, which we measure in environmental epidemiology. However, architecture is essentially a social project. It is where buildings are built, what kinds of funding they receive, the type of people that they welcome into their halls are all determined by the way that society is set up socially, politically, economically. And the disparities that we see across different communities, where you'll see, for example, one neighborhood where you'll have a much higher percentage of people over 65 who end up in the emergency room during a heat event versus another neighborhood with the exact same percentage of people in that demographic. It's related to the built environment many times, in the sense that one group of people maybe are living in buildings that aren't as well insulated, maybe don't have as much access to air conditioning. The tree canopy is not helping to lower the heat in that neighborhood. But the reason why those two groups of people are in those two different neighborhoods many times can be sourced. You can find the root of that cause is related to social discrimination, sorting out by either background or economics, who gets access to what level of built environment amenity. And so it's important to think about architecture not just as sort of a type of engineering that sort of creates a setting, but to also look at the social and historical background that put it in the position to lead to disparate outcomes in terms of the built environment. And so basically thinking about this from the perspective of people with different abilities, each community, this left-hand square, is exposed to different types of environmental hazards, right? I live in Houston, Texas. We tend to be exposed more often to hurricanes and flooding and heat. We're always exposed to air pollution because we're a port and we've got a lot of car culture. Places maybe out in the Pacific Northwest or in the Mountain West are more likely to experience drought and wildfire than, say, Houston. So there's these kind of larger environmental hazards. And then each property in a community experiences different exposures to those regional hazards. And those exposures can either lead to new disabilities or it could increase risk of an individual with an existing disability. Then if we think about the built environment itself, what is it about the buildings that are already in that neighborhood or maybe already on that location? Or what is it about the stormwater sewer infrastructure or the access to sidewalks, things about the built environment that can be seen as a determinant of health? Those buildings, transportation systems, and natural areas have place that particular population within that new structure or renovated building at a unique in a unique position, right, of either being protected or being exposed to some kind of climate change related hazard. And so what architectural epidemiology proposes is that we could use the design process as a point of public health intervention. And so that's what you see here in this big black rectangle, where at different scales, inside a building, in a home setting, you know, at a organizational scale, maybe healthcare facilities, for example, and then at the neighborhood and the transportation scale. At each one of those scales, we can intervene through design actions and remove barriers to health promoting behaviors, and also create barriers that are protective so that we are disrupting that environmental exposure pathway. And just like the socioeconomic and demographic disparities are playing out at the different, you know, levels of the social ecological model, if you think about, you know, an individual versus their family versus you know, being in the community, et cetera. You can think about that in terms of the way that design strategies would shift from one spatial scale to the next, and how they interact with those underlying social determinants of health, whether they're related to economics or racial or ethnic background, healthcare access, et cetera. And so let me just give you one simple example. Like I mentioned before, you might have two neighborhoods in the same city that have essentially the same group of people demographically, but that one group ends up going to the hospital during a heat event and the other one doesn't. Well, part of that might be related to the social construct of the people living in the neighborhood that's maybe more protected, has more green, you know, tree canopy, et cetera, more insulation. Those people, on average, are more likely to be homeowners. And so when we just think about, at least in the US, getting access to opportunities to upgrade your home, to make it more insulated, more resilient to different types of climate change related hazards, it's much easier for landowners to access those types of funding programs. And so they have more, not only are they starting out maybe at a higher level of security and less risk because of where they're located, and maybe they are higher income, have better access to medical care and all those kind of underlying social determinants of health. They also get access to things that they can do to improve the built environment more easily. And so they've got more freedom to make those adaptations, whereas people in that other part of the community on average would be more likely to be renters. And it's more difficult as a tenant to convince your landlord to make the changes to that building that would be more protective. So what we're going to do right next is we're going to kind of walk through this framework that I just shared with you, really thinking about it as design as the public health intervention. And we're going to look specifically at 4 design frameworks that center people with differing abilities in the design of buildings, transportation systems, and natural areas. I work mostly in the US, so these are systems that are used in the US a good deal. They also, most of them are, or at least some form of them are used in other countries as well. But we're going to start out with a law in the US that's called the Americans with Disability Act. And this is required for all building types except for housing. Housing has some protections under the Fair Housing Act, but it is a little bit of a loophole. And the Americans with Disabilities Act was really, it was put into law in 1990, and it's seen as a federal civil rights law. So the idea is that there's a recognition that people with different abilities were being discriminated against because of the way, not just the built environment, but organizations and other ways of, society doing business kind of had a blind spot. And so the goal of the ADA, and particularly the standards for accessible design, which you see on the screen, the design of buildings is now required to accommodate particularly people with limited mobility, to some extent, people who are vision or hearing impaired, but mostly it's limited mobility. And so like, that's the reason why, for example, I'm at a hotel right now. They happen to put me in an accessible room. So I have a closet, a shower with no threshold to get in, to, take a shower every day. And the reason why those types of accommodations exist is because of the ADA. But it really focuses on prescriptive requirements around minimum widths of hallways, with the idea that you're always thinking about people in wheelchairs. Do they have space to go one past the other? Can they turn around in a full circle? That sort of thing. Another approach so the ADA, everybody has to do it, right? And so all the other frameworks I'm going to share with you are voluntary on top of the ADA. And so we could think of universal design, which was a movement that started actually not in the US, I think maybe in Germany, but in the US, it sort of became more well-known in the 1990s through the Center for Universal Design at North Carolina State University. And this, here on this screen, you see a poster from their website that tells you what the principles of universal design are. And basically, its name sort of tells you what it's about. It's beyond just looking at barriers-free design. It's not just about making sure that people who have limited mobility are able to get around as easily as people who don't have limited mobility. It's looking at kind of all types of disability and trying to create a space where everything is usable by all people to the greatest extent possible without needing to specially design anything. A third way of approaching this topic is called inclusive design, which was kind of popularized around 2000-ish. It's about a decade after universal design. This principles that you see here were, so originally inclusive design, the idea is rather than a one-size-fits-all approach, which is the universal design approach, is a one-size-fits-one approach. So the idea is that everybody can move through a space and enjoy a space in the way that makes the most sense for them, and they can tailor that space to their needs, as opposed to thinking about one single approach that works for everyone, right? It was originally created as user interface technologies. So you'll see a lot of conversation about inclusive design for websites, for example. But then the Design Council in the UK came out with these principles that you see on the screen here that tried to then translate what had started out as sort of moving your way through an electronic space into like literally moving through a physical space. And how might the design of that space be different if you thought about it that way? And I think one of the most impactful aspects of inclusive design and its definition is that they're trying to broaden and destigmatize the definition of disability. So this is a quote from the Inclusive Design Research Center that's at the Ontario College of Art and Design University. Rather than a personal characteristic or a binary state of disabled or not disabled, disability is framed as a mismatch between the needs of the individual and the design of the product, system, or service. So with this framing, disability can be experienced by anyone excluded by the design, right? So if I have a hard time, I was going through a metro subway system a few months ago, and I couldn't figure out how to buy my ticket because the way the ticket machine was set up, I couldn't figure it out. You could say in that sense that I was meeting that definition. So lastly, trauma-informed design is something that is talked about a lot in the US as in relation to mental health. It was it is advocated for, and the evidence base for it is being built up a lot, in large part because of the U.S. Department of Health and Human Services Substance Abuse and Mental Health Services Administration, SAMHSA. And they've been really focusing on how do you create a trauma-informed approach to medical care, and particularly thinking about people who have experienced physical and mental trauma, such as service people and veterans who have served in action in some sort of armed conflict, or women who have experienced domestic violence, or people who have experienced housing insecurity or homelessness, and maybe also are trying to make their way through a substance abuse disorder. So it's really focused on trying to understand what the underlying needs are and what might potentially trigger a negative mental health response from a person, and building medical care around that approach. So about 10 years ago, a group of and I guess it was more than that, but about 10 years ago, the principles of trauma-informed design were released by a group of design practitioners. And the idea was to try to translate some of that evidence that was focused on medical care and mental health care to the built environment, understanding that the physical environment is actually one of the 10 domains of implementation that SAMHSA had identified as a trauma-informed approach. And also recognizing that, this is a developing area of research, and trying to understand how do you design a location or a building or a site, or, a transportation system, a public space, in a way that is inclusive and welcoming and can be healing in some way, but knowing that there are lots of different people who are going to be using these spaces, and they might be experiencing different types of trauma. And I included this framework because trauma and disability many times go together. You might end up with a disability because of physical or mental trauma, or simply having the disability can trigger trauma. So it's something to keep in mind as we start moving through the actual design strategies that we're going to talk about. So all four of these frameworks have a lot to offer us. They all really think about commonalities of, access and moving through space, using space. A lot of them think about wider pathways of travel, more options for vertical travel, so ramps and elevators instead of stairs or in addition to stairs. And they all emphasize centering the needs of the user, whose physical or mental health experience have historically placed them in the margins of the design conversation. The thing that they're missing is climate change. None of them talk explicitly about the amplifying effect that climate change has on the vulnerabilities of the populations that the frameworks were designed to protect. The one caveat to that is that the ADA, because it's a law, its non-discrimination requirements are universally used. So if you're going to build an emergency shelter, or if you're going to, say, build a building that's going to be used as an emergency shelter whenever there's a disaster, ADA requirements around widths of pathways and access to restrooms and accessible showers, all of those things, the height of your the sink to wash your hands, all of those requirements are have to be adhered to. So in that sense, it is incorporated somewhat into climate change preparedness planning, if you think about emergency shelters, but it's still there's a pretty big disconnect. And so what we're going to do today is that we're going to draw from those four frameworks And we're going to apply them to climate change and exposure to the hazards associated with climate change in 3 different types of environment. And then we're going to see the extent to which those frameworks can work in concert with green building strategies that are more directly geared towards supporting either climate mitigation, in other words, reducing greenhouse gas emissions, or climate resilience. And so what you see here on this screen is the sort of the symbols for the most used green building rating system in the US, and it's a pretty well known across the world as well. It's called LEED. Not all of the design interventions that I'm going to share with you are necessarily directly connected to LEED, and LEED is not exclusive. A lot of people use many other green building rating systems, but to just keep in mind that because that link hasn't been made for us, what we're going to do today, and then what we've done in the chapter in the book that Dr. Alexander mentioned, is to kind of help make that connection for you. So, all right, so we're going to look at the home environment, we're going to look at healthcare facilities, and then we're going to look at the community environment, neighborhood planning and transportation, that sort of thing. And we're going to think about both how people in those environments experience a climate hazard, and then design interventions that can be particularly protective for people with differing abilities. So if we think about hurricanes and floods, for example, they can create the conditions for both a direct risk to your physical and mental health. That could lead to a disability. It could also be a direct danger for people living with differing abilities. And that's, related to mobility challenges, but potentially also, other types of disability. So, for example, if you think about an extreme weather event that also occurs at the same time as an extreme heat event, this is happening right now, today, in Florida, right? Yesterday they had a heat index of over 100 degrees, and there is massive devastation that's occurred because of Hurricane Helene, right? In the next week or so, people whose houses weren't totally washed away, if they don't have power back and haven't been able to clean out and remove all the wet materials from their house, then mold growth is probably going to start. And about 2 weeks from now, there will probably be a bloom of mosquitoes, which could, depending on what type of mosquito, could lead to an outbreak of West Nile virus, of dengue, or of other types of vector-borne diseases. So a trauma-informed approach to designing in a place like Florida that is hurricane-prone would be to, consider all the different types of hazards that might be exposed in that home environment, based on historical information, but also climate projections, and then designing the project so that it protects physical and mental health specifically. So, this is, the way you would do that would be probably different for different people. But like one easy example is in Houston, where I'm from, most houses do not have windows that open, operable windows, which is crazy because the power goes out, right? So an easy, resilient solution that is really beneficial for people who have limited mobility is to have operable windows with screens on them. And if possible, cross ventilation, so that the natural sea currents will bring air through the house until the power goes back on. That's just one example. With power outages specifically, many people who have different types of disability are dependent on electrically charged devices. You see on the picture here, you see somebody in an electric chair. A lot of people have them electrically powered devices to either monitor their health or to actually perform, medical care in the home. And when the power goes out and they're trapped in their homes, that can be actually one of the main difficulties. for, in terms of causing either a health crisis or even a death. So opportunities to be proactive around that topic are to reduce the amount of electricity that the building's going to use to start out with. And that's the purpose of energy efficiency. Also, putting in insulation will keep it cooler in the house until, for at least a period of time. And then adding on-site renewables like solar power connected to batteries, that at the very least, or, if you don't have access to that, then maybe like a gas generator, will at least allow for those really important medical devices to be accessible. And that allows people to stay in their homes, which research has shown is the best. Sheltering in place is mentally and physically the best thing to do if it's safe in the home, rather than trying to venture out into potentially a dangerous environment to go find a shelter, which, where there might be a lot of people with, maybe they don't have the accommodations you need. Maybe, it's overcrowded, that sort of thing. There might be infectious diseases. So it's better if you can to shelter in place. And so having that ability to function will make that possible. For extreme heat events, all of the things I said about power outages can be very protective, as well as adding vegetation wherever possible. And again, this goes back to my example before. The amount of vegetation that you have access to or control over is going to be dependent on how much control you have over your property. And so if you're a renter, you're automatically at higher risk, unless you've got a great landlord that loves to plant green stuff. And then for vectors, so mosquitoes and ticks, the landscaping design can be tailored to encourage predators of mosquitoes and ticks and discourage those insects themselves. Plumbing and maintenance of plumbing is a really big, very important, because if you have leaks, that creates sort of a reservoir of water that pests kind of go to and use. And so they're kind of drawn and more likely to kind of set up shop in your house. So then indoor air pollution. This is can be kind of chronic, or it could also be connected to one of these events where the power goes out. Chronic exposure to indoor air pollution often is a result of pollution that's generated in the home. So that would be potentially like cleaning chemicals, gas stoves, or building materials like oil-based paint. My sister built kind of an addition to her house a number of years ago, and the contractor used oil-based paint for the trim. And I mean, that place is 10 years old and you can still smell it. So that is introducing unnecessary indoor pollution. You should always use water-based paint. And then when the power goes out, particularly during a heat event, what we're finding with more and more evidence is that those types of any of those materials that off gas chemicals, the amount that they off gas increases, sometimes exponentially, when the temperature gets above like 90 or 95, something like that. And so the indoor air pollution itself could actually bloom once the power goes out. And that's particularly true for mold. So design interventions really involve, designing with materials would be least likely to produce indoor air quality or indoor air pollution, and least likely to encourage mold growth. And then on the back end, remediating mold properly if it happens, and proper maintenance to keep moisture out as much as possible. In terms of outdoor air pollution, if you live near a source of outdoor air pollution, like a freeway or an industrial installation, it could speed cognitive decline among people with cognitive differences. It can trigger psychiatric disabilities. Outdoor air has a lot of negative impacts. And unfortunately, because people tend to live next to these sources, it becomes a chronic exposure. So the important thing to remember in the home environment is if your home does not have a way for outdoor air to come in through a filter to try to minimize exposure to that source. So if you're facing a freeway, you could plant trees and bushes that have, there's research showing which plants are the ones that are most efficient at filtering out different types of outdoor air pollution. If you have the ability to, turning all of those outdoor exposures away from the source, the farther you get from the source, the safer you are, the less air is going to get into your home. You could also filter the air, like with one of those plug-in HEPA filters. I still do that at my home. After that was sort of a legacy of COVID in our home. And so really kind of thinking about the type of disability you're dealing with and whether outdoor air or indoor air is an exacerbating factor would help determine the extent to which you would kind of go to lots of lengths to reduce exposure. The other thing to know about outdoor air is that bad outdoor air makes its way inside and then gets concentrated. And so in some places they found that you're actually at higher exposure to poor outdoor air quality inside, because particularly in houses, there's not usually a way for that air to leave. It's not mechanically ventilated out of the building. So let's move on to healthcare facilities. I'm going to do these next two a little bit faster to make sure we have time for questions and conversation. I'm not able to see the chat, but I see people are putting things in the chat, which is great. So I'll look forward to talking with you guys in about 5 minutes once I finish sharing a lot of the principles that make sense for a residential setting. Also make sense, but in a different way, kind of in a different context, when you move to the next level of the socio-ecological model and you're thinking about institutions and organizations, places that people go to work or go to visit. And then again, the next step up, which we'll be talking about, community design. And, you know, for the big question for healthcare facilities that are trying to support their population who might have limited mobility, but they might also experience other types of disability, is how do you make sure that people can access care during and after extreme weather events? So, you know, one way of working with the community on that is to ensure that the community transportation system is set up with universal and inclusive design principles so that it's and that it's resilient, so that it's less likely to be compromised or to shut down during an event. Then if you do experience that type of situation where it's just not possible to use public transit to get to the medical facility, then healthcare organizations sometimes work with other transportation options like Uber or even just emergency transport to bring their staff and you know, high needs patients into clinical care during these during a time when most people are not out on the roads. Another thing that can be done is partnering with facilities that are closer to your patients. So if you have a patient who really needs you know, kind of ongoing chronic disease care, and they're pretty close to a clinic or a pharmacy that could provide that care for them, allowing that to happen during an emergency event can make a really big difference in terms of patient outcomes. And then mobile clinics and telehealth. So thinking about how do you bring the medical care to the population. And again, the way you would do that would be different depending on the type of disability that you're talking about. The other side of it is once people get to the facility, what's it like there, right? Is the power on? Is the water on? And at least in the US, high acuity healthcare facilities are required to maintain operations for up to 96 hours. We have seen in some instances, like after major hurricanes, for example, where that didn't happen, and what ended up having to happen was evacuations. We see evacuations maybe more often in lower acuity facilities, long-term care facilities, nursing homes, because they're not required to have that on-site generator and water production. They unfortunately many times end up having to evacuate if the power doesn't come back pretty quickly. And again, those are a group of incredibly high-risk patients. So the way that a healthcare system or a hospital facility can increase its resilience and make sure that it's able to maintain operations is starting with efficiencies again. Efficiency is important both in water and energy because it means that it's easier for you to manage more of a larger percentage of operations than you would if you were, if you had a larger demand. So you want to reduce the demand as much as possible. And then to the extent possible, generate power online. There are a number of examples now across the country of cogeneration plants, microgrids, where the health facility or the healthcare campus becomes sort of the anchor for a distributed energy or distributed water situation that can disconnect itself and sort of become an island when larger infrastructures are shut down for a period of time. And then people have a tendency, we've seen this over the past 20 plus years, of going to healthcare facilities and using them as essentially ad hoc shelters because they feel like they're going to be safe there. There's more likely to be electricity and water. And so, knowing that these types of events are going to happen probably more frequently in the future, planning for that instead of being surprised every time it happens. And again, maybe even reaching out specifically to your high-risk patient population and say, we're here, we're available, you can help, you can come to us and feel safe, at least for a period of time after an event happens. So finally, in the community environment, one thing to think about is, if you're in a neighborhood or in a community where, there's different options for traveling around. It's not just cars. You can walk, you can bike, you can take transit. That is a more resilient community because it provides more evacuation routes during and after events. The problem is that people who have mobility challenges are more likely to have increased exposure to the environmental exposures that occur when you're in that environment, when you're outside of the car, right? Your exposure to traffic-related air pollution, to mosquitoes, to heat, to flooding. The list goes on. And so that in and of itself can be a reason, a motivating factor for building community resilience strategies that would reduce exposure to those types of environmental triggers and really would benefit everybody, but centering people with differing abilities in that design. And then finally, as I said before, thinking about evacuation routes and how transit stops are designed, what is the plan for different people with different types of abilities when they do need to, when sheltering in place doesn't work and they do need to move beyond to a safe spot. The way that transportation and land use is designed can really be supportive of that, or as we've seen in situations in the past in the US, the built environment, if it's set up as for only one thing, like in Houston, we're pretty much like individual cars. There's just not a lot of infrastructure beyond that. When you're set up like that, you really can place people in unnecessary harm's way. So having as many kind of redundancies as possible with your infrastructure can be incredibly helpful. So that's the end of my presentation. I know that it was kind of sharing a lot of details with you over a short period of time, so I hope it wasn't overwhelming. But I think the important thing to just kind of take away from this is that we have a set of strategies on one side that are centering people who navigate the world in lots of different ways, but maybe haven't been thinking about climate change so much. And then we've got a set of kind of validated green and healthy building strategies that really focus on climate change. And so what this work is doing is trying to kind of bridge those two. I do work in the US, and so I apologize for this being sort of a US-centric talk. So I'll talk about that in a second. But to reference the question about even people in industrialized countries or high-income countries accessing these types of strategies. So to me, the biggest barrier, if that question is targeted towards residential construction, the biggest barrier I see is rentals. What we see, at least in the US, is that you're more likely to be a renter if you're low income. And if you have a disability, you're more likely to be low income. Those two things are not necessarily, I mean, they're correlated, they're not necessarily associated, but you can see that you've got a population of people who are low income, who are renters. You've got a population of people who are low income, who are disabled. So there's going to be some set of those that are renters. And that's the hardest group, because it's hard to get access to funding. There actually is a lot of funding available for low income people in the US to upgrade their homes, to do a lot of the things that I was suggesting. It's just, you have to be a homeowner in order to access that funding. So that, to me, is the biggest kind of barrier that I think needs a policy response associated with, because the way that we, at least in the US, the way that we build is you get a permit, and then nobody ever comes and looks at your building again. It's not inspected. And we saw that conversation happening when there was this big condo that fell down in Florida a few years ago, and people were like, how could that possibly happen? It's because it's not part of our laws to go back and inspect buildings afterwards. So that's how you end up with rental housing that's old and maybe needs repairs, and maybe the landlord doesn't see it as being in their best interest to upgrade, and then your only choice is to leave and try and find a different place to live. So to me, that's a big issue. In terms of funding for the other two types of building structures that I was talking about, again, there's a lot of funding that's available for healthcare. A lot of hospitals and healthcare organizations want to and are interested and embrace green and healthy building strategies because they save them money. And they also are beginning to see that connection, like I said before, about continuity of care. So if you're able to continue to remain functioning during an extreme weather event, you are continuing to generate income for your institution. It is absolutely worth the investment to make sure that you stay functioning as an institution during that time. And so that would be a reason for those types of investment. And then ditto for, the community infrastructure. I interned at the UN many, many years ago in the accessibility department. And so I did learn something about accessibility, at least back then, in countries all across the world. And I do think that the principles, so I find these frameworks that I shared with you guys today can be really helpful as ways of framing questions. And you can make that question be a question related to the built environment, but you could also frame those questions in terms of how are you going to design your approach to clinical care, and how that's going to change, if you've got different types of patient surges during different types of climate change events, right? It's a way of asking questions that maybe we weren't asking before. I find that really useful. I find it not so useful that, because they're principles, it's hard to measure progress. But in a setting where maybe there's not as much data available, where the levels of infrastructure that's accessible to different people varies widely across even a single country, approaching this question as a set of principles might be a way of starting, at the very least.